So good afternoon. Welcome to all of you. This is our webinar number 6. And I'm Norbert Gorin from the Department of Hematology and Cell Therapy at Hôpital Saint-Antoine in Paris, and the present chair of the EBMT Global Committee. These are my disclosures for this presentation. As you can see, I am a member of the advisory board of Air in Space. And as I said, this is our webinar number 6. If you remember, the 5 previous webinars were devoted to fungal and essentially viral infections, and we focused on COVID, of course. But this time we thought we had to raise another issue, which is the multi-drug resistant bacteria. So why are we so much concerned? Well, first of all, it's increasing continuously, and it's deadly pathogenic. If you look at the sentence below, it's one of the greatest threats to human health worldwide, and this is recognized by the Infectious Diseases Society of America. It's linked to the large use of empiric broad-spectrum antibiotics, and the risk has been known, and warnings have been produced already 30 or even 40 years ago. Here we are showing, in fact, the increasing risk of the development of these bacteria in relation to what wards in hospitals. But in fact, everyone in hospitals is concerned. You will see, for instance, at the highest level of risk, allogenic stem cell transplantation, lung transplantation, but you will find also liver transplantation, heart kidney transplantation, many diseases, solid tumors in general, and immune disorders. So as indicated on the left side of this slide in red, hematology, ICU, infectious disease, transplantation, oncology, surgery, essentially orthopedics, and in fact everywhere. So everyone is concerned. There are various mechanisms of resistance of these bacteria, and I'm just listing here the most common known mechanisms, such as a diminution of the permeability of the LPS layer of the bacterial membrane so that the antibiotics do not go inside, or the overexpression of efflux pumps, which push the antibiotics outside, or the synthesis of antibiotic degrading enzymes, antibiotic target alterations, and finally, the transfer of resistant genes through plasmids, essentially for gram-negative bacteria. For those of you, and I think every one of us who is very interested, there has been a nice review last year on this subject, but there are many reviews. But this figure is of interest because you find on the left side the known mechanism for gram-positive bacteria. On the right side, the mechanism for gram-negative bacteria, and this is very important if we want to find new drugs, new means to cover the resistance to the antibiotics we have now. Before I finish my introduction, I want to remind you also that we have a problem with tuberculosis. Here in red, you have the increased incidence of latent tuberculosis infection in Mexico, and maybe Professor Ghafur from India will mention resisting TB, which are of considerable concern and which are re-emergent at the moment. There has been some attempts at classification of MDR infection. Generally speaking, we consider that the infection which develops up to the first 2 days of hospitalizations are community associated, just conventional. And after the first 2 days, by definition, it's nosocomial. I think it's very important to remember that patients tend to get reinfected with the same bacteria they have been colonized before. So prevention, of course, is of considerable importance, and we have highly sophisticated HEPA filters, or even more sophisticated filters, such as this one, Plasmare, which in addition to filtering and retaining bacteria, viruses, and fungi, in fact also destroy them in an oxygen plasma built environment. And this picture, as I like very much, is coming from Suzhou in China. And also the possibility to use biocare rooms where we can switch the pressure inside to be positive or to be negative according to our wishes. So after this introduction, and I want to remind you that we can do this webinar thanks to the help of the Air in Space unrestricted grant. Professor Carlet, President of the World Alliance Against Antibiotic Resistance, will cover the early management of severe infections. Professor Bertrand Guidet from our own hospital at Hôpital Saint-Antoine in Paris, and he's the head of the ICU department, will cover how to cope with multi-resistant bacteria precisely in ICU. And Professor Abdul Ghafur will give us his experience from India, where the situation is certainly more difficult than presently, at least in France. And to finish, do not forget that at around 3 p.m., we will have a roundtable and we will answer the questions. It will be live, but you can already ask your question from the first speaker. I will note them and we will try to give the answer and cover the topics during the round table. Thank you very much, and we meet again in an hour.
Hello to all of you. I'm very happy to be with you today, and I would like to say that I'm very grateful to Norbert, Claude, Gorin for this kind invitation. So the title I've selected is Therapeutic Principles for the Treatment of Severe Infections, including, of course, sepsis. So I don't detail my biography that you see on this slide. So it's very important in this area of severe infections to know exactly what is the strain responsible for the infection. So this was, if you cannot measure it, you cannot improve it. It was mostly for nosocomial infections, but we can very well apply this concept to what we will say today. So the main principles mentioned or not, I put or not because it's not necessarily detailed in the guidelines. In particular, the many guidelines published on sepsis. We have to treat very quickly, of course. Everybody knows that. 3 hours or even less. But each patient is unique. You cannot really put the same, have the same strategy for all the patients. So we need really to think about it very early in the process, avoid automatisms, and one of the automatisms are the use of very broad spectrum antibiotics and very recent ones, and this is not appropriate. It will increase antimicrobial resistance, AMR. So it is not really enough. We need, and this is key, to have bacterial samples performed before starting antibiotics and not after, because there is a risk to have nothing in the blood, and although it's still a bacteremia. Of course, blood cultures are key, and at least 2 blood cultures before starting antibiotics are needed. So time is very important. Okay, use the best diagnostic methods, of course, and prescribe an appropriate antibiotic therapy. And of course, this is a very difficult point that we will develop. Appropriate antibiotic therapy. But what does it mean? Several things are key. The site of infection, of course, sepsis, which is really a good example of severe infections, is supposed to be an infectious disease due to a precise microorganism or several bacteria, viruses, fungi in a precise site, or sometimes in several different organs, like for COVID. Sepsis, in my mind, is a syndrome. It's what we said from the beginning when the word were widely used. It's not a classical infectious disease. It's a syndrome. However, there are rarely people in this group of sepsologists who are now considering that sepsis is a real disease. I don't think so. I fully disagree with that. And the risk is really to push clinicians to consider that, okay, there are symptoms of sepsis and that's it, without really making efforts to detect which kind of bug is in this setting, and then use broad spectrum antibiotics for several weeks. And they think that it's an appropriate behavior. I don't think so. So, well, in the large studies performed in sepsis, for example, only half of the cases, the microbe was found. So it's really a shame, and this is because it was not really, the samples has not been made early enough. Of course, one of the key parameters to take into account is the level of antimicrobial resistance in the country in which you are treating the patient, and the level of antibiotic resistance are very different from one country to another. And I will show you several data on that. Of course, we usually need to use a very large spectrum antibiotic therapy empirically, because we don't have necessarily the microorganisms before some time, 2 days, for sometimes a bit longer. But then, and it is now a classical concept, a re-evaluation is mandatory, really, and this is not always done. And of course, if you do not try to de-escalate, it's the one which is used, in particular to try to find a therapy with more narrow spectrum antibiotics, and then you are obliged to continue this broad spectrum for a week. However, the problem is that we don't really know, at least is what I think, what is a broad versus narrow spectrum. As an example, if you switch from a carbapenem to piperacillin plus tazobactam, both are of very broad spectrum. And so it's not, we don't really have enough information really to do this switch and to find broad spectrum antibiotics. So it's okay, it's widely said, but it's still a bit theoretical. Of course, we have to use appropriate dosage, usually far above of classical ones. And pharmacokinetics is also very important. Often combined therapy, 2 or sometimes 3 antibiotics, but it is usually very easy to stop one of the 2 antibiotics rather quickly. It's a good example are aminosides, which are widely used. Just to show this slide that attributable mortality of, in this case, bloodstream infection in the ICU is influenced widely by the type of the microorganism, and so this is very important because it does influence mortality. As I told you, resistance varies a lot according to different countries. And on this slide, you can see the prevalence of Pseudomonas aeruginosa, resistant to carbapenems, in several European countries, which provide enough data, like in the EARS network, which is, of course, given and provided by ECDC. And so you see the difference, important difference between countries in yellow, for example, with a very low prevalence, and other ones which you can see are, let's say, invited by a very resistant Pseudomonas. It is similar with the Klebsiella pneumoniae, as you can see on this slide, resistant to carbapenem, and you can see that it's very high. It's even outside the slide. In Greece, also a bit less in Italy or Romania, but pretty low. In other countries, it's increasing a bit, but you can see that. So see the difference. It's incredible. And of course, we cannot propose similar strategies between Greece and countries like France, for example. Another issue is that there are bugs which were considered as colonizers and very non-aggressive microorganisms, but they became really very infectious, let's say, and pretty aggressive. And it's the case of Acinetobacter baumannii. And to illustrate this, you see the results of the Eurobact study, which was a study on ICU bacteremia all over Europe. And you can see there that Acinetobacter is the most prevalent microorganism found in this study, which is incredible, because this would not be the case at all in several countries, including France, countries in which the prevalence of Acinetobacter is really very low. So, of course, there are reasons for that. But again, the message is that you cannot really treat patients with the same strategy in Greece, for example, and in France. So this was a slide showing that again there was many in the slide in Greece. So from the same study, Eurobact. And you can see that in Greece, for example, you have really a lot of strains which are MDR or sometimes XDR, so extremely resistant. A few are pan-gram resistance, but it's only a few. And the adequate empirical treatment, as you can see on the bottom of the slide, had a protective effect upon mortality. So, of course, so therefore, of course, in those kind of countries, they use extremely broad antibiotic therapy using very, very recent and costly, by the way, micro antibiotics. We know, of course, must consider as well the trends of resistance over years. And this again is provided by ECDC and published this paper on Open Forum for Infectious Disease. And you can see that Staph aureus, the resistance for this microorganism, which was considered as a very important marker of resistance, is decreasing over years sharply in France, or even more sharply in the UK. So of course you cannot have the same strategy if you consider 2001 at the beginning of this network and now. So the usage of, for example, vancomycin should not be the same than 20 years ago. For E. coli with ESBL, we were at that 10 years ago, or even a bit more, people were very afraid, extremely afraid, in particular politicians, to see that the E. coli, which were really always susceptible to, for example, cephalosporins, were becoming resistant. And it's why sometimes it's said that, okay, we will come back to pre-antibiotic area time, and which was not what happened. Now this resistance is really plateauing around 10% in most countries. You can see that it's higher in some other ones like HIV. So it's not a drama in several countries, in particular in Europe, but it is in other countries, in particular, again, in Greece, but of course, Asian countries or other ones, but in which really the level is extremely high. So then they use carbapenem or other combinations. And lastly, you can see that it's similar for VRE, which is high in several countries, as you can see on the slide. What you cannot see is that it is very, very low, close to zero in many other countries, including Scandinavian countries, but also France. It's so again, why is it so? Very low levels in several countries like France, in which people usually think that the resistance is extremely high, and other countries, why is it so? It's not that clear. I think that in France, it's due to the fact that the hygienic unit, infection control unit, are very extremely quick to detect those strains when patients enter the hospital, and then have very strong isolation procedures. It is not the case in other countries. So we are in a period which is very difficult for a lot of countries, but not all. Then we use antibiotics or combination of antibiotics now widely, cephalosporins plus beta-lactamase inhibitors, or even carbapenems with many different beta-lactamases, some of them very, very costly. And sometimes, very often in several countries, we have to use old drugs like colistin, which is not, of course, a drama, but those kind of antibiotics were not used for years, and it's, of course, impressive that we have now to use it again. So just to conclude, I think that you understood, or at least I tried to make this message very strong. One size does not fit all. We have to really to avoid those kind of automatisms, which are very important to create AMR, by the way. And we have to reflect before treating. I will not develop the concept of really treat very urgently. The only thing I want to really make very strong is that we need samples before starting antibiotic therapy. Then we have a lot of things that we need to do. But the message I tried to give is that guidelines, usually you mention a few things concerning antibiotic therapy, not enough, by the way, but they cannot be universal. They have to be targeted according to several items, but mostly targeted for the different countries, which is, it is not simple to include this in guidelines, because no room for that, or people are not necessarily interested in this concept. Of course, as infectious disease specialists, we are. And we have to change antibiotic therapy, initial and of course empirical therapy. In many cases, we have to try to do that. An example, and it's the last word in my talk, then, for example, you have to switch from vancomycin to methicillin, for example, if the staff is susceptible to antibiotics, MSSA. So it's not really known. It's not mentioned in the guidelines. And it's very important, in particular, because vanco is not the bactericidal. And it's not the best, it's not the appropriate therapy for MSSA. I thank you very much for your attention. It's a very important topic, at least infectious disease people are very, very interested in those kind of topics. Not necessarily people specialized in let's say, the sepsis. Thanks again.
This talk is about multi-resistant bacteria in intensive care units and how to cope with them. I have no conflict of interest besides honorarium for this lecture. So we will talk about epidemiology, screening, and preventive measures in intensive care. So what are we talking about? We are focusing on multi-drug resistant organisms. So this is mainly methicillin resistant Staphylococcus aureus, and even more important in intensive care is extended spectrum beta-lactamase producing enterobacteria. We will refer to ESBLE for those bacteria. So they are mainly hosted in the GI tract. They might be community acquired, but also hospital acquired. They are mainly transmitted by hand and feces. And there is a kind of continuum between those organisms and the very highly resistant strains. So those highly resistant organisms, we are referring to glycopeptide resistant enterococcus, and more importantly in intensive care, carbapenemase producing enterobacteria, but only in ICU CRAB, that stands for carbapenem resistant Acinetobacter baumannii. Some highly resistant bacteria are not classified in this group. I'm referring to Pseudomonas aeruginosa and Enterococcus faecalis resistant to glycopeptide. So ESBLE is increasing worldwide, but as you can see in this graph, it is really increasing in Southeast Asia and also in Eastern Mediterranean countries, but to a lesser extent for countries located in Europe. When we're focusing on Klebsiella pneumoniae, you see that there is a change over time with much more bacteria resistant because they produce ESBL. And as you can see, for example, in France, it was green in 2005, and now it's orange in 2020, saying that Klebsiella pneumoniae now are resistant in more than 25% of the cases. So resistance is increasing over time, and it is mainly focused on a few bacteria. In the opposite, the Staphylococcus aureus resistant to methicillin are decreasing in France as it is in other countries. But enterobacteria producing EBLSA is increasing. Now I have the data for APHP hospital, that is all the academic hospitals located in Paris area. And you can see that in my hospital, we are facing patients with highly resistant bacteria, accounting for 3% of those bacteria, and extended spectrum beta-lactamase for more than 15% of the patients. And when we look at the type of units where you can find a high prevalence of those resistant bacteria, it is mainly in intensive care. You can see that for the whole hospital of APHP, you have patients with enterococcus resistant to vancomycin and also carbapenemas producing bacteria. So we have a problem in general because it's increasing over time, but we have a specific problem in intensive care unit. When we look at the risk factors for having such bacteria, again, in this study, you find that being admitted in intensive care is a factor for carriage of such bacteria. When you transfer from another hospital, and mainly from foreign countries, it's increasing about 10 times the risk of this type of bacteria when you have been hospitalized in the previous year, and for sure when the patient is known to be a carrier of such bacteria. So with those factors, you might identify high-risk patients for having such resistant bacteria. And again, when we look at the map of Europe, you see that the carbapenem resistant organism is really increasing in the south part of Europe, mainly in Italy, but even more in Greece. So it's increasing over time, and it's related to different bacteria. E. coli, it's less than half of the bacteria, Klebsiella pneumoniae, and all other germs. And sometimes we are facing two resistant bacteria together. And the mechanism for resistance to penem drug, you can see that OXA48 is decreasing over time, while new daily strains are increasing over time. So there are some guidelines for dealing with such patient, and I will go through those details. The first question is, do we need a single room or versus other room or double room in intensive care? You can see that there is a kind of overlap, so there is no strong evidence for suggesting that single room perform better than double room, but still the tendency is in favor of having a single bed room strategy. And when you look at the impact of the type of precaution, this is contact precaution, and this is standard precaution. And when you look at the prevalence of ASBL, it's lower when you implement a contact strategy. This is the same for acquisition of ASBL. And also, but the difference is not significant for colonization pressure. Among the bacteria, we need to identify E. coli, because non-E. coli enterobacteria carries a much higher risk of transmission. So probably the strategy to screen and isolate the patient should be different, whether enterobacteria is an E. coli or a non-E. coli bacteria. So there was a study that was performed in France involving 73 different intensive care units. So it was a survey asking about the characteristics of the units, the infection control and hygiene dedicated team. You can see that there are some differences according to the ICU, whether there is a team for the hospital, etc. But more importantly, when you look at the screening policy among those 73 ICU, you can see that mainly that there are procedures for screening and isolation policy, but the content of the procedure is different. Sometimes it's systematic for screening, but in other ICUs, it's only when there are risk factors as identified previously. And what type of swab, nasal swab, cutaneous swab, and the modalities of implementing the isolation procedures. And the isolation procedures could be different according to the type of bacteria. So this study suggests that there is a huge heterogeneity from one ICU to another one, suggesting that there is no strong evidence for performing this or implementing this type of policy versus another type of policy. When you look at isolation policy, you can see that there is a preemptive isolation and admission in 82%. And this isolation continues throughout the ICU stay in only 8% of the cases. This isolation is systematic until screening results and only targeted according to risk factors. So again, there are some discrepancies, some heterogeneity among ICUs. And again, it depends on the type of microorganism that is isolated. And when you look at contact precaution, that is the use of gloves, the use of gowns, you see that again there are some discrepancies, but when you have contact with blood and body fluids, they use gloves in all the cases, 100%, and but gowns that are used almost all the time when there is contact with the patient or with contact with blood and body fluids. When you compare the ICUs with multi-drug resistant organism outbreak or no outbreak, there is almost no difference between the two. So again, suggesting that this is not that easy. So probably other factors, and mainly compliance with the recommendations, are important to consider. So to finish, I would like to focus on a publication we had with colleague Jean-Christophe Lucet. Is working in Bichat Hospital. He's the head of the IACH department. And Antonio Harris is from the US, and he published a great paper in the JAMA a few years ago. So we were asked by the European Society to provide a recommendation for contact isolation. And we said that it depends on several factors. The first one is the patient. So when you consider the patient, you need to consider the burden of the bacteria, and when there is diarrhea, urinary tract infection, wounds, we favor contact precaution over standard precaution. When the workload is high, we favor contact precaution. And when the patient is at high risk of infection, that is vulnerable, mainly patient with immunosuppression, we believe that this patient should have a contact precaution implemented. The second factors that needs to be considered is epidemiology. So the local epidemiology, whether it's endemic or sporadic outbreaks. So if there is an outbreak, you don't want to disseminate the bacteria to other patients. So again, this is in favor of contact precaution. The type of multi-drug resistant organism, if it's extensively resistant, highly resistant, again, we don't want to spread the bacteria to other patients. So we need to be very cautious, and we suggest to have contact precautions. As I told you, we need to differentiate E. coli from non-E. coli bacteria producing ASBL. So if it's an E. coli, we might suggest standard precautions, while if it's a non-E. coli bacteria, we are in favor of contact precautions. And finally, the route of dissemination, when it's by cross-transmission, again, we want to implement contact precautions. The third factor is a healthcare workers practice, and it is mainly related to hand hygiene, that is the use of alcoholic solution. So if hand hygiene is very high or very low, we might use standard precaution, while if it's intermediate, that is between 40 to 70%, we suggest to use contact precaution on top of hand hygiene, because this suggests that the compliance is, I would say, intermediate. You can use a surrogate for compliance with hand hygiene, which is the consumption of hydroalcoholic solution. When the consumption is low, this suggests that the compliance is low. And again, in this situation, we feel that we should use a contact precaution. And the resources, the environment, if it's crowded, we need contact precaution. If we have a single room, and this is important again to avoid dissemination to other patients. If there is a screening of patients, if there is no screening, maybe it's limited use of having contact precaution. Human workforce, because it takes time to implement contact precautions. So if you have a shortage of nurses and helpers, it will be very difficult to implement contact precaution. And financial resources, again, because it takes time and it will be difficult to implement such a policy in ICUs with a limited amount of funding. So the last slide, it's the policy we implement in my ICU to deal with multi-drug resistant organism. First, I have to check for previous electronic record to look for carriage of such organisms. We need systematically to ask for travel and hospitalization in the previous months. And if a patient is requested to be transferred from another country to France and to my units, I want to be involved in the decision, because it might be very difficult when we have to deal with a patient with such highly resistant bacteria. For sure, we need to implement contact precaution and admit the patient in a single room. And we need extensive screening, and we need to isolate the patients until the results are known. Another population is the vulnerable patient, that is the patient with immunosuppression. mainly the patients coming from the hematology department. We need to be very cautious with those patients. So we need, again, extensive screening upon admission, and we need to admit the patient in a single room. I really thank you for your attention, and we might need to go through some questions if you want to. Thank you very much.
Good morning, good afternoon, and good evening. I am Dr. Abdul Ghafur, a consultant in infectious diseases, Apollo Cancer Institute, Chennai, India. The challenge of preventing and managing extensively drug-resistant gram-negative infections in the Indian oncology and BMT setting. Opinions expressed are solely my own, and in the past, I have received advisory fee, lecture fee, travel or research grant from multiple generic and international pharmaceutical or device manufacturing firms operating in India. Apollo Cancer Institute, Chennai, is a 300-bedded oncology center, and we have a well-established hematopoietic stem cell transplant program. Save antibiotics, save lives, an Indian success story of infection control and antimicrobial stewardship to persuasive diplomacy. This is a paper that we published in 2012 based on the AMS data of our hospital in 2009 and 2010. And that was well before India had a national antibiotic policy in 2011. And that is well before the famous Chennai Declaration by medical societies in India. In 2010, when we did our AMS work, or at least when we published the data of our AMS work, the carbapenem resistance in E. coli and Klebsiella was just 1%. Yes, of course, the carbapenem resistant Acinetobacter was as 80% even at that time, and Pseudomonas was 25% even at that time, as was the statistics in most Indian tertiary care hospitals and in several other countries. But the carbapenem resistant E. coli and Klebsiella rates were very low at that time. And then, even at that time, we had a very strict policy on usage of high-end antibiotics. Any patient on the restricted list of high-end antibiotics needed an infectious disease second opinion within 48 hours. And patients on other antibiotics who are not receiving the restricted list of antibiotics, even those patients on other antibiotics for more than 5 days needed compulsory infectious disease second opinion. And this was in 2010. This is our high-end antibiotics daily checklist in 2011. Every day, we keep a list of patients on high-end antibiotics, and all these patients must be seen by the infectious disease consultant. And you can look at the list, a daily list in 2009 and a daily list in 2010. At that time, the aim of our antimicrobial stewardship was reduction in high-end antibiotic usage. Because we know at that time, the AMS was more straightforward. One patient, one bug, one antibiotic. And we know the situation is different now with multi-drug resistant gram-negatives and the era of combination therapy. And at that time, yes, the aim of the antibiotic stewardship was reduction in high-end antibiotic usage. And now we know it is not just reduction, it's actually rationalization and more rather than reduction in the high-end antibiotic usage. Now then in 2012, despite very strict infection control and very tight antimicrobial stewardship program, the E. coli and Klebsiella carbapenem resistance were steeply on the rise. And that's when we realized the carbapenem resistance in Enterobacteriaceae will increase in your patients unless other hospitals in the country follow similar successful AMS programs. That's why I took the leadership in creating the Chennai Declaration by medical societies in India, with the support of colleagues from across the country, with the help of medical societies, other governmental and non-governmental organizations. Our aim was to help the Indian hospitals implement successful antimicrobial stewardship program. Our aim was to inspire our government to implement the national antibiotic policy, because we realized whatever we do, whatever good work we do in our hospitals will not be fruitful from an AMR perspective unless other hospitals in the country follow similar programs. This is the 2012 data. The mortality of patients infected with carbapenem-resistant bacteremia was significantly higher than the mortality in patients with carbapenem-sensitive gram-negative bacteremia. And then we know that was the era of carbapenem-colistin combination therapy. Patients with drug carbapenem-resistant gram-negative significant serious infections received colistin carbapenem combination therapy because we trusted the synergy of the combination of colistin and carbapenem. But later, we found out, and others also found out, the carbapenem-colistin combination therapy is not superior to the colistin monotherapy. And in our center, we knew the reason, because the MIC of our carbapenem-resistant gram-negatives were more than 16. And if MIC is more than 16, the carbapenem-colistin combination therapy will not work. And 2014, the E. coli and Klebsiella carbapenem resistance was still increasing. And this is a stool screening study we conducted on 1,000 healthy volunteers in the community in the Indian metropolitan cities. We found at that time, that was 2015 to 2017, 6% of the healthy Indians living in metropolitan cities at that time had carbapenem resistant gram negatives in their gut. And I'm sure the rate is much higher now. This is a meta-analysis by a global team on the mortality of patients with carbapenem-resistant Klebsiella infection. And this meta-analysis includes the data from my hospital as well. And we found the patients with carbapenem-resistant Klebsiella pneumonia bloodstream infection had a twofold risk of death compared with carbapenem-sensitive Klebsiella pneumonia infected patients. At that time, colistin was the mainstay of treating carbapenem-resistant gram-negative infections. And even today, colistin is the mainstay of treating carbapenem-resistant gram-negative severe infections. And we have extensive experience in using colistin. This is a single large series from India on colistin nephrotoxicity in adults from our center. What we found was the colistin nephrotoxicity rate is not high. It's just 13%. It's a low rate. The reason could be our experience of using colistin. And the similar data came from many other centers from various countries. The colistin is not as nephrotoxic as we thought it is. Could be because of our experience of using colistin. But the colistin resistance rate was on the rise in our center, in other centers in the country, and in several countries. You could see that the carbapenem resistance, the colistin resistance in E. coli and Klebsiella was rising significantly by 2016, 17, and 18. And colistin is used as a growth promoter. The holy water of our hospitals is being used as a growth promoter in poultry in India and other countries. Colistin as a growth promotional usage was extensive in India at that time. And what we did, we collected, our center, we collected fresh food samples from the community and we tested for colistin resistant bacteria. What we found was 50% of the raw food samples were positive for colistin resistant bacteria. Based on the data that we published, the Indian government in 2019 banned the growth promotional usage of colistin in poultry and animal farming. That's a landmark step by the Indian government. At the same time, we collected stool samples of our hospitalized patients. We found a good percentage of the hospitalized patients have colistin resistant bacteria in the gut. But interesting fact is, they are not the colistin resistant bacteria acquired from the hospital. Majority of this colistin resistant bacteria are very sensitive to other antibiotics. They are not like the whole hospital colistin resistant bacteria with resistant to almost all antibiotics. No, they are the food bacteria. From the growth promotional usage of colistin in poultry, the food is contaminated. We consume that food and our gut get colonized with these colistin resistant bacteria, even for the hospitalized patients, because they are from the community. And so we screened the stool samples of healthy young volunteers from the community. We found 15% of the healthy young Indians are carrying colistin resistant bacteria in the gut. And again, these are derived from the food, from the phenotypically, from the antibiogram, and by the molecular analysis. And that's what we found. This is the data we collected just before government banned the growth promotional usage of colistin. It will be very interesting to assess the contamination of colistin resistant bacteria in food and the fecal carriage now after the colistin growth promotional ban. But the carbapenem resistance in E. coli and Klebsiella are still increasing. Though the Acinetobacter carbapenem resistance is marginally coming down, yes, the carbapenem resistant rate in Acinetobacter is still high, but the number of patients getting infected with carbapenem resistant Acinetobacter in our hospital is quite low. Even though the resistance with Acinetobacter is high, the number of patients getting infected with this bacteria are low because of the strict infection control standards. But the Pseudomonas carbapenem resistance has significantly come down over the last few years because Pseudomonas is our hospital bug and we have got a control on these bugs. While E. coli and Klebsiella are the community bugs, they're gut bugs, patients bring it from the community and from other hospitals. So the antimicrobial stewardship, the main aim is not reduction of resistance, not the control of AMR by itself, because antimicrobial resistance is a socio-economic challenge. What's happening in the community, what's happening in the other hospitals, and the socio-economic indicators affect antimicrobial resistance rate. At the same time, the antimicrobial stewardship main aim is rationalization of antibiotics. Rationalization of the antibiotics in patients infected with drug-resistant bacteria. And this rationalization helps in improving the outcome of these patients. Antimicrobial stewardship is a patient safety measure and not just a measure to control the public good of antimicrobial resistance. We have a large team for antimicrobial stewardship, the team of infectious disease doctors, nurses, management staff, clinical pharmacists, and information technology team. And we have an excellent compliance to our high-end antibiotic policy over the last 15 years. More than 85% of the patients on high-end antibiotics within 48 hours and other antibiotics within 5 days get infectious disease second opinion. And what is the secret of our success of AMS program in our hospital? That is the trust between the primary consultants and the antimicrobial stewardship team, because our infectious disease consultants examine the patient, document the findings and recommendations. We don't just preach. Our ID team go in and do it. And our infection control and AMS team back them up. This shared medico-legal responsibility generates trust between the primary consultants and the AMS team. This trust helps us follow persuasive diplomacy strategy. We keep on persuading until we get what we desire on a daily basis. Over weeks, months, years, and more than a decade. We all know that the drug-resistant gram-negative is one of the challenges that we face in our oncology patients. In a country like India, tuberculosis is a big challenge. 1/3 of the Indians get infected with tuberculosis bacteria at some stage in their life. And every year, India reports 2.5 million cases of active tuberculosis every year. And no doubt, Indian patients with hematological malignancies are at high risk of developing clinical tuberculosis. However, there's a scarcity of epidemiological data of TB in patients with malignancy in Indian oncology centers. Even our own center, we are in the process of compiling the data of tuberculosis in our cancer patients. And this is the unpublished data from another oncology center in the country. And I'm presenting this data with courtesy to Dr. Nitin Bansal, my colleague in another center. And they had 59 patients over 4 years in a large oncology center. Half of them lymph node tuberculosis, and 1/3 of them pulmonary tuberculosis, and 13% disseminated tuberculosis. Acute myeloid leukemia and lymphoma were the most common conditions. The message is we must suspect TB in hemato-oncology patients in TB endemic countries, and invasive investigations whenever feasible to diagnose tuberculosis, and watch out for drug-drug interaction, especially rifampicin interactions with chemo drugs like venetoclax, imatinib, and other drugs. Fungus is a serious infection in all HSCT centers anywhere in the world. This is the data, our data of invasive fungal infections in HSCT patients between 2014 and 18. This is the data we are going to publish. A very low rate of proven, probable, or possible invasive fungal infections in our HSCT patients. In fact, during this period, we did not have a single patient of candidemia in our HSCT patients. Yes, this could be because of excellent antifungal stewardship, excellent infection control standard, and more than that, the good usage of rational and good usage of antifungal prophylaxis in our HSCT setting. Managing drug-resistant infections is a big challenge in any oncology centers. But if you have a successful teamwork and innovative strategies, we can ensure good outcome of our oncology patients. If you want to go fast, you go alone. If you want to go far, go together. Thank you.
Abdul Ghafur, I confess I was very much interested in your talks, and so I'm saying this with pleasure. Now we are going to the round table, and I have several questions who already came up, and probably some more. I'm checking one more time. Some more, yes, will appear. To start with one question I was not expecting, GCSF and GMCSF. Of course, I am a hematologist, Abdul Ghafur also. What do you think? I mean, I will start maybe with Abdul Ghafur, then Bertrand Guidet, then Jean Carlet, and I can give my opinion. Do you use G or GM CSF to treat your patient, neutropenic or not neutropenic?
As Professor Gorin, you are a hematologist, I'm an infectious disease physician. You
Correct.
know much better than me on the usage of this drug. But as you know, and all of you know very well, the usage of whether GSF, GCSF or GM-CSF in febrile neutropenia is controversial. We don't really know how, from an infection perspective, whether it will be reduce the prevalence of infection or early recovery from infection is not really proven. There's a controversy among infectious disease physicians treating cancer patients and among the oncohematologists.
Okay. Bertrand, do you have an opinion?
Everybody, hello to everybody. To prevent infection, yes, we tend to use those factors, but we don't use GM-CSF, we use GCSF because sometimes it's pretty problematic to activate macrophages. Well, this is for prevention. For active infection, there was several trials testing the use of GCSF, and in fact, it was detrimental. So now we're not using those stimulating factors when the infection is active. So we use it as a preventive measure because we want to reduce the duration of granulocytopenia, but in intensive care, we tend not to use them when the infection is active.
Okay. Jean Carlet, do you have an opinion?
Yes. First, hello, Bertrand. Hello, Abdul. Very happy to see you. Well, in severe infections and sepsis, for example, you know that we moved from a period in which hyperactivity of the inflammatory system was the main factor considered. It's why we use a lot of drugs which were anti-inflammatory. But we then moved to a period in which immunodepression, post-sepsis, was really becoming more and more well-known. By the way, it's at the same time hyper-inflammatory and hypo-inflammatory, let's say. So people tried GCSF or a few GM-CSF without spectacular effect. So I don't see really in the, let's say, acute period of severe infections and sepsis any place for those drugs.
So, Abdul, you mentioned that I am a hematologist. I will give my opinion. I agree with everything that was said. We don't use it to treat patients, but to prevent, yes, especially patients who do receive consolidation courses, for instance, for lymphomas. Well, chemotherapy courses for lymphoma, if you take R-CHOP, for instance, and then it's ambulatory and they go back to home, they have a prescription that in case the neutrophil count goes below 500, then they would receive GCSF. But the main reason is, in fact, to be able to give the next course of chemotherapy. Now, if they are febrile, they do receive GCSF. But I remember when I was younger that there was a big controversial discussion about GM-CSF that we do not use anymore and that we may have, but usually it's difficult to get in aspergillosis. So this is not the topic of our discussion today, but for fungal infection, there was this idea that GM-CSF could add something, but in my view, it was never proven. So it's not in the guidelines. So I'm speeding up, and now I'm going to another question. Again, it's not really our talk, but Dr. Sadi Mukaddam is very eager to have us explaining, I'm not sure we can do that, the use of teicoplanin in endocarditis. And the only thing I know is that teicoplanin, as compared to vancomycin, it's very near, in fact, very near but maybe is more effective against Streptococcus, while vancomycin would be, that's an old remembrance I have from the past, more effective with Staphylococcus, but there is also amoxicillin. Any of you has an idea, and we go fast to another question?
No,
If you look at the, oh, fine.
Sorry,
No, fine.
Go ahead,
Bertrand
please.
and Abdul. Bertrand and Abdul.
Yeah,
If you read
depends
the
on-
idea, oh,
No, Bertrand first,
no, Guidet,
Abdul after.
Guidet.
I'm sorry, I didn't mention. Bertrand and Abdul after.
Okay, it depends whether we are dealing with a Staphylococcus or Streptococcus. With Staphylococcus, now we have new drugs that are very potent for treating endocrinitis. And this is daptomycin, which is very efficacious, and also linezolid. So we tend to use less vancomycin or teicoplanin because of the side effects, and to use those new drugs for Staphylococcus aureus endocarditis. And also it depends on the type of valve that is involved by endocarditis, whether it's a aortic valve, mitral valve, or tricuspid valve. So we tend to use less and less teicoplanin and use new anti-staphylococci antibiotics.
Okay, Abdul?
Yeah, I agree with Professor Guidet. If you read the Infectious Disease Society of America guideline, you will not see teicoplanin. Of course, teicoplanin is not licensed in US. But if you read the BSAG guideline, it's a bit old guideline. There's no recent guideline. Again, there is no recommendation for teicoplanin in staph endocarditis, but there's a recommendation in enterococcal endocarditis.
Okay. I have several questions. I know we won't go over everything. Yes, one question I'm sure you cannot answer. Why Greece and Italy? Why do we have this increase that you showed? I think Jean Carlet and Bertrand Guidet, you, Abdul, you are in India, but we showed your curves with a high incidence of multi-drug resisting bacteria in Greece and Italy, and I was thinking of a possible answer. I don't know, it's the Mediterranean Sea, or maybe is it the same for the Indian Ocean? I don't know. Do you have any explanation why?
Jean Carlet, yes, we don't really completely know the reason why, for example, it's so high in Greece. But we can hypothesize that it's probably a combination of an overuse of antibiotics and probably a suboptimal precautions and infection control. But I cannot say that this is for sure. So the best answer would be we don't know exactly. There are probably many other factors.
Okay. Bertrand?
Yes, I think they are lacking a specific team to look after policy. I mean, screening policy, isolation policy, antibiotic stewardship, etc. So I think it's a bunch of factors that are combined. But if you don't screen the patient, if you don't identify the multi-drug resistant organism, then you don't implement isolation policy, and you have a spreading of the bacteria, and then you use new fancy antibiotic, and you push for resistance to those new antibiotics.
Abdul?
Professor Gorin, it's a very interesting question. We have been wondering for some time. There's a similarity between South Asian countries and Mediterranean countries on the prevalence of gram-negative resistant bacteria. At the same time, if you look at the situation in the United States or even UK, I'm familiar with, the MRSA rate is more common in these countries compared to India. I don't see MRSA usually. For me, MRSA bacteremia, I see an MRSA bacteremia once in 2 months and not more often. I see a carbapenem-resistant Klebsiella, E. coli, Pseudomonas, and Acinetobacter, E. coli Klebsiella every day. Acinetobacter less often, Pseudomonas probably more common than Acinetobacter. And this is probably the same pattern in Mediterranean countries. It may not be just because of antibiotic usage or infection control, because antimicrobial resistance is a socio-economic challenge. If you look at the 2019 paper, a wonderful paper by Peter Collington and team, the finding was the antimicrobial resistance rate is not directly proportional to the antibiotic usage per capita. It's directly proportional to the socio-economic indicators like governance, potable drinking water, sanitation component. So it's more often a socio-economic factor rather than the volume of antibiotic usage. And that could be the difference between the resistant, and this is seen in gram-negative bacteria. There is some relationship between a volume of usage with MRSA, but not with the gram-negative resistance. So this could be the reason of the disparity between the Mediterranean countries and the other European countries in the prevalence of gram-negative, more of a socio-economic governance and administrative aspects rather than just the volume of antibiotic usage. In India, we know why we have high E. coli and the Klebsiella carbapenem resistance. Again, the socio-economic factors like sanitation. That's why I explained, even though my hospital follow the best, we are not perfect, but best of the ability, infection control and antibiotic stewardship. In Enterobacteriaceae, it makes less of an impact because patients are bringing in carbapenem resistance. Few years ago, we did a stool screening study with RPCR of new admissions. 1/3 of the patients coming to my hospital at the first screening are positive. They're bringing from the community and from the other hospitals. At the same time, as I explained, my Pseudomonas rate is coming down because I do have some control on my Pseudomonas. So it's a really complex when it comes to the gram-negative resistance.
Okay, so now we come to the last question. I left it for the last part of our discussion because it's going to be tricky. It's a question of protected environment. As you know, I can make the introduction. In hematology, we have been convinced for decades that we need especially for severely neutropenic patients, immunosuppressed patients, acute leukemia, transplantation, and now even CAR T cells, we need a protected environment. It's not totally consensual, but the majority of hematologists use protected environment. They also have gowns, gloves, hand washing, everything you may dream of, but in addition, protected environment. Bertrand, you presented the results of the survey, the large survey, and you said, for instance, that in fact, there was a trend in favor of a single room as opposed to a double room. But even a trend is something important because it means that maybe you don't have a big enough statistical power, and therefore it could be in fact true. Then I saw also in what you showed, yes, screening, you had a p-value of 0.06. I took this note when you were presenting the data, when comparing the contact precautions or no contact precautions, I don't remember exactly, but p 0.06, I know it's a trend, but it's a serious trend because if I remember my use and statistical studies, it would mean, but our statistician would not like me to say that, but it would mean that the probability that there is no difference in the two is only 6%, if you reverse, the conclusion. So what do you think about prevention of infection using protection environment, using HEPA filters, using plasmar that you know. What's your opinion? I know it's difficult. I will start
No.
with Bertrand, then Abdul, and then Jean.
So I will differentiate airborne microorganisms and microorganisms that are mainly transported by ants. So for airborne, we didn't discuss this because we were more discussing multi-resistant bacteria, but for sure we have multi-drug resistant tuberculosis. We discussed this. I guess it might be a problem in India, as it is sometimes in France. We have the problem with some virus, and so we want to protect the patients. So maybe we want to clean the air of the room because we don't want to disseminate those type of microorganisms to other rooms. So this is one question. For this very specific question, where the problem is how to deal with the door. Do we need to keep the door closed, or can we keep it open? If we close the door, there are some drawbacks. There are some evidence that then you have less visit from the healthcare workers, and it's increased our workload, and maybe decrease the quality of the surveillance of the patient. So maybe for this type of patients, if we fear a high risk of dissemination, we might want to implement kind of cleaning machine like a plasma or something to reduce the burden of the microorganism. For enterobacteria, it's totally different. It's mainly related to hand hygiene, and that is hydroalcoholic solution usage, and to wear gloves when you are dealing with blood and fluids. That is contact precaution. So we should differentiate according to the type of microorganism. So cleaning the air for multi-resistant enterobacteria, I think it's not an issue. We need maybe to clean the environment. But for airborne microorganisms, there might be a place, yes.
But you know what? I was thinking while you are talking in China, they put plasmars in the corridors. So I was impressed that they put, for instance, 3, 4, 5, 6, even 8 plasmars in the huge corridors so outside the room. Any idea about this?
No.
Abdul, what do you do in India?
See, India is an endemic tuberculosis country, but there is a disparity between the number of tuberculosis cases I see in my cancer center, in my oncology infection practice, and my general infectious disease practice. We don't know the real. Every day I see tuberculosis patients in my non-onco ID practice, but I don't see that number of tuberculosis cases in my oncology practice. For example, if I look at my inpatients, I don't have a single inpatient today on anti-tuberculosis therapy in my oncology center. Yes, I do have even oncology center. There are OP patients with anti-tuberculosis therapy, especially lymph node tuberculosis patients. Why is this disparity? I'm wondering, but as I explained before, we haven't got good quality data on the prevalence of tuberculosis in Indian oncology center. There is one published paper, small series, another unpublished paper I just discussed from another center. Even on my own center, I'm currently collecting the data on tuberculosis. What is the disparity? Why, even if tuberculosis is so common in India, why my oncology patients have got less number of tuberculosis? But I work in a tertiary care or corporate setup. By most of my patients are very affordable population. And, you know, the situation may be different from ordinary oncology centers. This may be, again, the economic disparity of my oncology patients with the overall general population. That could be one of the reasons. But overall, I don't see a lot of tuberculosis in my leukemics, Lymphoma, yes, mainly lymph node tuberculosis, but not a lot of tuberculosis cases. Now, coming to the point on our bone marrow transplant center, of course, as everywhere else, we use HEPA filtration, positive pressure. We don't use the standalone air filters. Yes, there are few rooms in the hospital with such filters available, but it's not a standard practice. We don't know how useful they are. We need more quality of data. I haven't done any studies on these standalone filters. It's worth doing studies on the additional protection provided to the patients, especially when we move out BMT patients from the BMT unit to an ordinary room at a later stage. That's probably the situation where we may have to look into the role of standalone filters.
Okay. Jean, I am sorry. I'm sorry, we have to stop. The host is going to disconnect us. So our time is over. So I'm sorry. So again, thank you very much to the three of you. Thank you so much. Maybe we will join again in another webinar one of these days. And thank you to the audience. I have a few questions we could not answer. Okay, thank you. Bye-bye.
Goodbye. Goodbye.
Bye-bye.
Ciao.
Bye-bye, Jean.